This conference will now be recorded.
Hello everybody, can you hear me?
Yes, ma'am.
Hello. Yeah, very good. So after a long time, I'm taking a class for you. Hope all of you are preparing well for your exams. Yes? Hello. Are you preparing well for your exams? And no reply. Okay. Today's class is on BREECH presentation. So all of you would have heard this topic many times before. So BREECH presentation is, in general, what do you mean by presentation? It's a part of the fetal bole which is occupying the lower segment of the uterus, and it is the first one to engage when labor starts. So all of you should be aware of all the definitions of lie, attitude, presentation, position, denominator, all those things by now. So BREECH presentation is where the podalic pole is occupying the lower part of the uterus, whereas head is at the fundus. So the incidence of BREECH presentation depends upon the period of gestation. So when the baby is a preterm, or when it is growing, the head will be relatively larger than the buttocks. So the head will go and occupy the largest area in the uterus, that is the fundus. So BREECH presentations usually indicate a prematurity. So at 32 weeks of gestation, you find more than 15% of the fetuses present as a breech, because the body is small when compared to the head of the baby. Head is large, so it goes and occupies the widest fundus. So as the baby is growing, the buttocks of the baby will increase compared to the head, and so the baby is spontaneous, and also because of the gravity, and also because the head is heavier than that of the podalic pole, it drops down. So spontaneous version occurs near a term, right? So at term, more than 15% will present as BREECH presentation, whereas as the baby is maturing, the incidence comes down to hardly 3 to 5%, right? So majority of the term fetuses, they present as vertex presentations. Okay. So types of breech are classified into complete breech and incomplete breech. Complete breech means where universal flexion is there. Flexion at the hip joint, flexion at the knee joint, everywhere it is flexed. It is called as a complete breech. Incomplete breech means where one or other joints of the lower limbs are extended instead of flexion. So when there is flexion at the hip joint and extension at the knee joint, that means both the limbs of the babies are over the head. The feet are actually touching the head of the baby. Then you call it as a frank breech. That is extension at the knee joints. Whereas knee presentation is where there is extension, knees are presenting. That means there is extension at the hip joint but flexion at the knee joint. Footling presentation is where there is extension at the knee joints so that the feet, both feet are presenting. So these are the varieties of breech presentation: complete, incomplete. Incomplete, depending upon the flexion and extension of the lower limbs, it may be a frank breech, it may be a knee, or it may be a footling presentation. So this is a complete breech presentation. So you can see everywhere there is flexion. Okay, head is flexed, upper limbs are flexed, lower limbs are flexed at both the joints, at the hip as well as at the knee joints. So universal flexion is maintained with the thighs are flexed both at the hip and the leg. So you find that when you are doing a pelvic examination, you can find the buttocks along with the feet also may be felt in a complete breech. That's how you will differentiate between a complete breech and a frank breech. Among all these varieties, frank breech is more common than the other presentation. So incomplete breeches, as we have already discussed, so this is a frank breech where there is complete, there is flexion at the thigh and there is extension at the knee. So both the feet are near the head of the baby. So this is a frank breech. So this frank breech is supposed to be a favorable presentation when compared to the other types of breech, because this is a well-fitting. See, now the lower limbs do not have any small parts of the fetus, unlike the previous complete breech. Look at the complete breech. Along with the buttock, even the legs are also there. Okay. Whereas in a frank breech, this is a well-fitting presenting part, right? It fits to the cervix very well, and then the bitrochanteric diameter is also the same as that of the suboccipital phlegmatic diameter, that is in vertex presentation 9.4 centimeters. So it's a well-fitting part. Cervical dilatation goes on very smoothly. When the membranes rupture, there is no danger of cord prolapse and other things. And usually, vaginal delivery, assisted vaginal delivery is usually, assisted breech delivery is favorable in these cases. So this is a footling presentation, right? Say one leg is coming out. As soon as the membranes ruptures at 2 centimeters, 3 centimeters. So premature rupture of membranes is very common in, this is a ill-fitting presenting part. So one leg may come out, or along with it cord also can come out. The same thing happens even in a complete breech. Complete breech also, premature, this is not a well-fitting presenting part. So premature rupture of membranes, cord prolapse, prolapse of one foot outside, all those things are common in the other presentations other than the frank breech. So of all the types of breech presentation, frank breech will have a favorable prognosis for assisted breech delivery, right? So this is knee present. We also have a knee presentation, and then the footling presentation will have a worst prognosis. And we said frank breech has got the best prognosis for assisted vaginal delivery, assisted breech delivery, whereas footling breech will have a poor prognosis because of the chances of PROM and cord prolapse, foot prolapse, and other things, right? So this is about the types of breech. And you can also classify breech not only depending upon the flexion extension of the lower limbs, depending upon the associated obstetric conditions like preeclampsia, multiple pregnancies, placenta previa, and other contracted pelvis or this. So when no other obstetric or medical problem is present, you call it as an uncomplicated breech. An uncomplicated breech means there are no other associated obstetric complications. It's only a breech, only a malpresentation is the problem with the pregnancy. Everything else is open, and you have excluded prematurity. So complicated breech are the conditions which are associated with adverse prognosis, like multiple pregnancy, prematurity, placenta previa, contracted pelvis, polyhydramnios, all those things. Right? In all cases, always you have to exclude anomalies, not only in breech presentations. Everywhere, first thing you have to do is exclude anomalies. So what is the etiology? Why some fetuses are choosing to present as breech rather than the 97%? Only 3 babies are choosing to present as breech. So most of the cases we don't know the obscure, but these are the known factors which are responsible. So prematurity, as we have already discussed, it is the most common cause. Whenever you have, you see a woman with a breech presentation, first thing you have to exclude is the gestational age. Okay, always exclude prematurity, because most of the women are illiterate. They don't know their LMPs properly. So always confirm by the height of the fundus clinically, okay, and also by the ultrasound. Then we already said it undergoes spontaneous version. They undergo spontaneous version in, as the baby is maturing, we are going for spontaneous version. That is, head will come down and then the breech will go up because of gravity and heaviness and large podale pole compared to now head. So what are those factors which are preventing spontaneous version? These are multiple pregnancies. So multiple pregnancies cannot rotate because there is no space for 2 babies to rotate. So other baby is hindering that, right? Then oligohydramnios, when sufficient liquor is not there for the baby to move. Then anomalies of the uterus like a septate uterus or a bicornuate uterus, which prevents spontaneous version of the baby. Then short cord and intrauterine death of the fetus, of course, we have to exclude in all cases. Anomalies and IUDs have to be excluded. So these are the factors preventing spontaneous version. Then in some cases, it is favorable for the baby to present as breech rather than as cephalic, like whenever there is a large head, so hydrocephalus. Okay, so it goes and occupies more space in the uterus, that is the fundus. Then placenta previa, where there is less space in the lower uterine segment. Then contracted pelvis, also same thing. Beaking, particularly in a gynecoid tendencies, the anterior space is reduced, so it goes and occupies the fundus. Then corneofundal attachment to the placenta. So these are supposed to be the causes for a favorable breech presentation. So the baby finds it better to present as a breech breech. Then undue mobility of the fetus. So hydramnia, polyhydramnias, where the baby keeps on changing, which you call it as a unstable lie. So one day you examine, it will be vertex presentation, the other day it will be oblique, some other day it will be breech, then again it becomes transverse, then again it becomes cephalic. So when there is so much of liquor, the baby keeps on moving, and that is known as an unstable lie. So polyhydramnias may be the reason for the undue mobility of the baby. Then multiparous women with a lax abdominal walls and a lax uterine walls. Then fetal abnormalities like trisomies, anencephaly, and myoptic dystrophies. So congenital anomalies have all should be excluded in all cases of breech presentation. So what are the known causes for breech presentation? Prematurity is the most common cause. Factors which prevent spontaneous version. Factors which favor breech presentations, undue mobility of the baby, and anomalous baby. Right? So how do you diagnose breech presentations? Right? So first, clinical examination. So per abdomen, you are doing all the grips, lipoabdominal fundal grip. You find that the head will be present in the fundal grip, which you will diagnose by its hardened globular mass, and you can move it. That is known as ballotable head. So when you are doing the fundal grip itself, instead of the soft, broad podalipole, you will feel the small, hard head, and which is capable of independent mobility. That is ballotable. Okay. Whether it is complete breech or the frank breech, everything, you always find a head, and along with the head, you find small parts of the feet may be felt. So these things will be felt only if the patient is very thin and she has got a thin abdominal wall and a thin uterine wall, and she is very cooperative. Otherwise, usually in a frank breech, you will not be able to make out the feet of the baby mostly. It is only the head you will make out. And in these cases, head may not be velatable because of the splinting action of the legs on the trunk. You may not be able to move it. So that's one of the reasons where external cephalic version also becomes difficult. So fundal grip, head will be felt, which is small, round, hard, and ballotable. So lateral grips is the same thing. As you in the vertex presentation, you will find fetal back on one side and irregular limbs on the one side. Here also, you find irregular parts on the less felt on the side. So here also you can feel the irregular parts and back on the other side, unless the back is posterior. Then do a first and second pelvic grips. You will feel the breech as suggested by a soft, broad, irregular mass. Okay, and here also you find same podalipole. Along with that, sometimes you may feel a something like a limbered knee joint can be felt sometimes, small, hard, conical mass, and so on. So breech is usually not engaged during the pregnancy. It starts engaging only when the labor starts. Whereas in a frank breech, because it is a well-fitting presenting part, it will be engaged just like the head which engages in the later weeks of pregnancy. In the same way, frank breech also engages in the later weeks of pregnancies. So these are the abdominal examinations. Most important is fundal grip. You will feel the head. And in the pelvic ribs, you will feel the soft, broad, and large podalic pole, right? Fetal hearts are usually located at a higher level round about the umbilicus. Normally, in a cephalic presentation, fetal heart you will hear in the spinal umbilical line below the umbilicus. Okay. So here you will find around umbilicus. If the breech is already engaged, you will find in the lower level. The pelvic examination will be done only during labor most of the times, during pregnancy, because the cervix will be already closed. You will not be able to make out these parts. Okay, so during labor, when you do a pelvic examination, you can, so when the cervix is dilated, you can palpate the ischial tuberosities, the sacrum, and the feet by the side of the buttocks. And the foot that is felt can be identified by the prominence of the heel and less mobility of the greater toe. Right? Sometimes you can mistake the foot for the hand also. Right? So always you have to look for the great toe. You will be able to feel. So all these findings are better felt when the cervix is dilated, and more when the membranes are already ruptured. It is easy to feel all these parts directly. Whereas in a frank breech, you can feel the ischial tuberosities, the anal opening, and then the sacrum. All the three will be in a same straight line. Sometimes this anal opening can be mistaken for a face presentation mouth. So there you have to remember that both the malar eminences and the mouth of the baby will form a triangle. Whereas here, the ischial tuberosities and the anal orifice will be in the same straight line. And if you put a finger into the membranes are ruptured and you put a finger into the anal canal, you can feel that the sphincter closing over your finger. So that's how you will differentiate a frank breech from that of a face presentation. So even in a face presentation, sometimes are mistaken for a breech, or breech is mistaken for a face. So you have to look for the eminences, malar eminences, and the mouth opening will form a triangle. They are higher. Whereas here, ischial tuberosities and the anal opening are in the same straight line. If you put a finger, you can feel the gripping action. So that's how we can diagnose the breech, both by abdominal examination and vaginal examination. But of course, now because we have ultrasound readily available, it's more easier to diagnose by an ultrasound. So always confirm it by the ultrasound, confirm the clinical diagnosis. So the moment you put the probe, you will find the head is in the upper region, the breech is in the lower part. And not only confirms the presentation, other advantage, other information you can get by an ultrasound is you can detect any congenital anomalies like hydrocephalus and other ones. You can also know the type of breech depending upon the flexion extension of the lower limbs. You can know the gestational age by measuring the biparietal diameter, estimated fetal weight, fetal female length, AC, HC, and so on. Then most important is localization of the placenta, amount of LICA. Then the most important thing is the attitude of the fetal head. So head should always be flexed in a case of a breech. If you want to allow her for a vaginal delivery, that should be well flexed. If the head is extended, you call it as a stargazing attitude. So previous days, when we never had this ultrasound, we used to take an X-ray. So in the X-ray, if you find that the head is extended, it is down. You call it, that means the baby is looking at the scar up. So scar gazing attitude, it is extension of the neck. So this is an absolute contraindication for vaginal delivery, right? Here you find that the head is not well flexed, but it is not extended either because it's a preterm baby. So these are the additional information. Confirming the diagnosis, you know the anomalies, you know the type of breech, measure the gestational age, localize the placenta, assess the AFI. And then the most important to decide for assisted vaginal delivery is attitude to the fetal head, whether it is flexed or extended. Extended head is known as a star gazing attitude, which is an absolute contraindication for allowing this woman for vaginal delivery. Now, so what are the positions? So sacrum is the denominator, as occiput is the denominator in vertex. In breech presentation, sacrum is the denominator. So you have a left sacro-anterior, which is more common. Then you have right sacro-anterior, when it is on the right side, this is on the left side, right? And then this is the left sacro-posterior, and then the right sacro-posterior. You also have transverse is also possible, left sacrotransverse, right sacrotransverse. Among all these positions, most important is left sacro-anterior, right? So these are the positions. Denominator is sacrum, and the engaging diameter is, what is engaging diameter? Bitrochanteric diameter, which is same 9.4 centimeters, right? So you should know the lie. It's a longitudinal lie. The presentation is breech. Okay, the denominator is sacrum, right? The position is most common is left sacro-anterior, just like left occipito-anterior or left occipito-transverse. Here also left sacro-anterior or left sacro-transverse are the common positions. And then the engaging diameter is bitrochanteric diameter, which is same 9.4 centimeters. So these are the 5 things you have to write before you proceed to write for mechanism of labor. So mechanism of labor is not as easy as in the vertex presentations. Why? Because the lower parts, the breech is a soft structure, is it not? Not many bones are there. So it's easy for the baby to deliver up to the head. The problem comes with the head, which is referred to as the after coming head, because it is coming after the delivery of the breech. You call it as after coming head, right? So this is more complicated. Why we are so, though it is the incidence is only 3%, why we are so worried about a breech presentation and more number of cesareans are being done for breech presentations nowadays because of difficulty in the aftercoming head, leading to either too rapid delivery or a very late delivery, leading to birth asphyxia and increased perinatal deaths, right? Intrapartum or immediate neonatal deaths, low Apgars, all those things. The hypoxic ischemic encephalopathy, then fractures of the shoulders, all those things. Okay, it is more complicated when compared to the normal delivery, that is a vertex delivery. So delivery usually occurs in 3 stages here. One is the delivery of the breech. Next are coming delivery of the shoulders and delivery of the after coming head. I should just don't say delivery of the head, delivery of the after coming head. So these are the 3 stages at which the delivery of a breech will occur. That is delivery of the breech, delivery of the shoulders, delivery of the after coming head. Now engagement occurs only during labor. So what are the cardinal movements? Here is compaction with descent. So here instead of saying flexion, we are saying compaction because we don't know whether the baby's lower limbs may be extended somewhere or the other. If it is a frank breech, there is an extension at the knee joint. If it is a knee, there is extension at the hip joint. If it is footling, there will be extension at the knee joint. Like that, somewhere or the other, you have an extension. And we already said frank breech is most common. Is it not? So the cardinal movements are number 1, engagement, same as in vertex presentation. Engaging diameter is bitrochanteric diameter usually engages in the opposite oblique diameter. If it is LSA, it engages in the right oblique diameter. Then instead of saying descent and flexion, we said descent and compaction. So whatever attitude, whatever joint flexion or extension is there, the idea is the baby should become more smaller and smaller, so that it corresponds to the uterine ovoid, it corresponds to the curve of Keras. So engagement, instead of saying descent with flexion, now we say descent with compaction. The baby should become more and more compact. right? This is the first movement similar to that of the flexion. Then internal rotation. They're also the same thing, internal rotation, right? After the internal rotation occurs, then how will the baby come out? The baby can come out only by lateral flexion of the spine. So this is equivalent to the extension of the fetal head. So after internal rotation, how is the head coming out? It's coming out by extension, whereas here the breech can come out only by lateral flexion of the spine. Okay, so this is the mechanism of labor. Okay, first engagement. After engagement, descent with compaction. Then there will be internal rotation at the level of the ischial spines. So the anterior buttock will hitch underneath the symphysis pubis, and then this has to flex. There should be a lateral flexion of the spine, then only the breech can come out, right? So by the flexion of the spine, the breech will come out, right? So this is the delivery of the breech. Then comes the delivery of the shoulders. Lastly comes the delivery of the aftercoming head. Okay, right? So delivery of the cardinal movements are engagement, descent with compaction, then internal rotation, and birth of the baby. That is, birth of the buttocks is by lateral flexion, which is equivalent to extension in cases of a vertex presentation, right? Then comes the into the same thing. This already I have told you. The engaging diameters is by trochanteric 9.4, right? Shoulders on nakarlu. Descent of buttocks till anterior buttock touches underneath the pelvic floor. Then internal rotation occurs to 1/8 of a circle. Then further descent with lateral friction till the anterior hip hitches underneath the pubic symphysis. This is followed by posterior and anterior hips and then the lower limbs. Then comes the restitution. Restitution will cause to go back to its original position. Okay, if it is on the left side, it will go back to the left side. If it was on the right side, it will go back to the right side. So these two, you don't need the same thing in head and shoulder presentation. Shoulder presentation, of course, we don't have a normal delivery at all, right? Then, so this is the mechanism of labor: engagement, descent with compaction, then internal rotation, then bilateral flexion of the spine, the baby is born. Okay. The shoulder circulation. So delivery of the buttocks, delivery of the shoulders, and the shoulder diameter is again bisacromial diameter. Here also the same thing again, descent to the shoulders, then again they undergo internal rotation, right? Then delivery of the posterior shoulder, followed by delivery of the anterior shoulder, then restitution. Right? Okay, always the principle and delivery of the shoulders, always remember that the posterior shoulder is always at a lower level when compared to the anterior shoulder, so that the posterior shoulder will be delivered without any problem, and then the anterior shoulder will be delivered later. Now, so the prognosis for the mother and the baby, maternal, there is increased incidence of operative delivery. Just now I have told you that the cesarean section rates are very high in breech presentations. Then genital tract trauma, infection, anesthetic complications due to operative delivery, and increased morbidity. And for the fetal, the perinatal mortality is around 9 to 25%. The perinatal deaths are almost 3 to 5 times more than the vertex deliveries. Then fetal mortality is less in frank breech. It is maximum in footling presentation. That I have already told you. Frank breech has got the best prognosis among all the other types of breech. Footling has got the least adverse, outcome. A poor outcome is footling presentation. Then the factors which are influencing the fetal death, the most important factor which is influencing the risk of the baby is the skill of the obstetrician. This is the single most important factor which decides the fate of the baby, because now that more and more of So single most important thing is the skill of the obstetrician. Okay. Now that more breeches are delivered nowadays by cesarean section, the art of conducting an assisted breech delivery is being lost. So the single most important factor which influences the fetal prognosis in assisted breech deliveries is the skill of the obstetrician. So it is very, very important that at least we should train these young obstetricians, at least take up a mock drill and then explain them how to conduct an assisted breech delivery. Because that's one of the ways why we want to conduct vaginal delivery, why not a cesarean? One is to reduce the maternal morbidity. And essentially, the steps of delivery are the same, whether you are conducting vaginally or whether you are delivering abdominally. The steps of delivery are the same, right? Same stages. Delivery of the shoulders followed by delivery of the buttocks followed by shoulders followed by after coming head. Everything is the same, right? And sometimes the patients may come in late in labor in cases where it takes time to shift to the theater as an emergency. In such cases, when the breach is already seen at the vulval outlet, then sometimes it's easier to do conduct a vaginal delivery. So at least perform some mock drills, show them on and then train them. Then the weight of the baby is very important. A large baby, it becomes difficult and least prognosis. Then the position of the legs, frank breech has got a better prognosis compared to footling. Then the pelvis is another important factor, right? Because if the pelvis is contracted, this is one of the reasons why we have to do a pelvic examination, pelvic assessment during the later weeks of pregnancy. Because what is known as a trial of labor in vertex presentation. What is trial of labor in vertex presentation? When we are suspecting a minor disproportion or minor contracted pelvis, that means any diameter is shortened in any plane, one diameter in one plane, then you allow them for vaginal delivery, hoping that the mother will increase her diameters by the relaxin. So all the diameters will increase by around half a centimeter. And the baby will also reduce its own diameters by overlapping of the skull bones, right? So that is called give of the pelvis and molding. And the most important so you have power, passenger and passage, is it not? All the three. So here passage is doubtful. So other two things, power is important. That is the uterine contractions should be adequate. So those are the ones which are bringing about all this descent with compaction or flexion, all those things. So type of the pelvis is very important. Where you have a trial of labor for a vertex presentations, in minor degree disproportion or minor contracted pelvis, you don't have such a fetopelvic disproportion. Here you call as fetopelvic, not cephalopelvic. It's not the head. So don't have such a type of trial of labor for breech presentations. So if you find that either the interspinous diameter is less or the diagonal conjugate is less or the pelvic outlet is narrow, subpubic angle is narrow, arch is narrow, intertuberous diameter is admitting only 3 knuckles. When you find any doubt of the pelvis, always better to take for a cesarean section. There is no trial of labor in cases of contracted pelvis and breech presentation. So these are the two important factors. One is, the most important is the skill of the obstetrician and the other one is the type of the pelvis. Next comes the weight of the baby and type of the pelvis. Type of the breech. Then what are the fetal dangers? Intrapartum fetal death, that is during delivery, either because of rapid delivery or because of delay in the delivery of the head. So the maximum we allow 8 minutes from the delivery of the buttocks to the delivery of the after coming head. So anything more than 8 minutes, there will be cord compression leading to intrapartum fetal hypoxia, and the baby will have a very low UPGAR at birth and it may die in the neonatal period or it may be stillborn. So injury to the brain and skull in the form of intracranial hemorrhages, petechial hemorrhages, fractures of the skull, birth asphyxia, birth injuries, hematoma of the sternomastoid, hematoma of the thighs when you are holding the baby very tightly, then also can produce rupture of the liver, spleen, all those visceral injuries. Then when you are forcibly delivering the hands of the baby, there may be hands or legs, a fracture of the femur, humerus, clavicle, odontoid process, visceral injuries like liver, kidney, lungs, then brachial plexus injury when you give undue traction over the shoulders. Then there may be Erb's palsy and Klumpke's palsy, and long-term neuronal damage in the form of cerebral palsy, intellectual difficulties, and so on. Then prevention of fetal hazard. Then what shall we do? One is reduce the incidence of breech. You can try for an external cephalic version in the later weeks of pregnancy. It is after 36 weeks. So if you do before 36 weeks, the baby is going to again turn back again. So it will be a failure. Then deliver by a cesarean section, but cesarean section is not the answer for fetal good prognosis because the steps are the same as that of the vaginal delivery. Okay. Then vaginal breech delivery should be done by a skilled obstetrician, and we should have a neonatologist and anesthetist together. And you have to carefully select cases for a vaginal breech delivery. That is known as an assisted breech delivery because the baby needs assistance at some part or the other. So management of breech presentation, antenatal period, that is during pregnancy. If the breech presentation is persisting even after 34 weeks, that means you have ruled out prematurity, then you have to try to find out, is there any etiological factor? All those etiological factors we have enumerated. Okay, congenital anomalies, factors which are preventing version, factors which are favorable, all those things. So if no etiological factor is found, then you can try for an external cephalic version. So up to 34 weeks, the breech presentations are common, and many of them undergo a spontaneous version, right? After 36 weeks, it is very, very rare for correction to occur. And 60% of the breech presentations version can be successfully attempted if we can do it properly. So what is the purpose of doing an external cephalic version? That we are bringing the cephalic pole to the lower pole of the uterus, right? So we are turning the baby. So for a breech is in the lower pole, we want to substitute it with the cephalic pole, which is at the fundus, should be brought down to the lower pole of the uterus. That is known as external cephalic version. This we are doing externally without any internal manipulations. The timing of the procedure should be around 36 weeks. If you do earlier, there are the chances of reversion back again. The breech will go back to its original breech presentation again. If you do late, that is after 38 weeks, as you know that the baby will increase maximum in the last 4 weeks of pregnancy, and the liquor also reduces. So because of reduced liquor and because of increased size of the fetus, we will not be able to do an external cephalic version late after 38 weeks. So the best time is to do between 36 to 37 weeks. So what are the benefits of doing an external cephalic version? We are reducing the incidence of breech at term. We are reducing the incidences of breech deliveries. Most important is we are reducing the incidence of C-sections. That is important. So because most of the breeches are delivered by cesarean section, the most important advantage of an ECV is reduce the number of incidents of cesarean sections. So now everywhere now on throughout the world, there is an attempt to reduce the C-section. That's the reason why most of the breeches are delivered by, not most, selected cases of breech we can do ECV. Some cases we can do assisted vaginal delivery after careful selection. And then even previous cesarean sections are, they are allowing a more number of women for vaginal delivery, TOLAC, trial of labor after cesarean section. Even previously they used to say only one previous section can allow for TOLAC. But now the latest guidelines say even after two cesareans, the woman can be given a choice of TOLAC. So ECV will be successful whenever it is a complete breech, not frank breech again, unfortunately. So because frank breech is the most common type of presentation in breech, these extended legs will not allow the baby to flex. So flexion is important for turning the baby, is it not? Because the crown rump length of the baby, now you don't call it as crown rump, but the diameter from the top of the head to that of the buttocks will be more than the transverse diameter of the uterus. So when you are trying to bring down, at some point or the other, the baby has to become transverse, is it not? So if the baby is not flexed, spine is not flexed, we will not be able to turn the baby, right? So that's the reason why in complete breech it is possible, because they are flexed everywhere. The attitude is flexed. We will be able to do a successful ECV in complete breech. Whereas in frank breech, these two limbs over the abdomen will prevent the flexion of the spine. So it will be a failure in frank breech. Then a non-engaged breech, that means breech has still not gone into the pelvic inlet. Then sacro-anterior positions are more common than, more advantageous than posterior positions, just like occiput. Then adequate LICA should be there to move the baby, and preferably the baby, the mother should not be very obese. So the chances of success of ECV will be more in complete breech, unengaged breech, sacro-anterior positions, adequate LICA, and non-obese patients. So increased failures will be seen in frank breech when there is a short cord. In case of short cord, there may be a problem of snapping of the cord, or there may be separation of the placenta, APH. Those things will be there. Uterine malformations like septate and bicornuate uterus, you will not be able to turn the baby. Scanty liquor, large babies, and obesity. So these are the cases where we will not be able to turn this baby. So deeply engaged breech also we will not be able to do an ECV. So ECV procedure, how is it done? It's done as an OP procedure. So don't do, no anesthesia should be used. So if you use anesthesia or excessive sedation, then you might be using more pressure than that is required to turn the baby, which may lead to uterine rupture of the uterus, right? So administer a tocolytic, either terbutaline 250 mics or isoxsuprine 550 to 100 mics IV. Then do an ultrasound, again confirm the position of the baby and amount of LICA. Do an NST, make sure that the NST is reactive. Then empty the bladder of the patient. Position of the patient should be supine with the shoulders slightly raised, thighs are flexed, and abdomen is fully exposed, just how we examine in the antenatal OP or in IP. Then presentation, position of the back, limbs should be checked, and auscultate the fetal heart. Then it can be done either by a forward roll method or by a backward roll method. Commonly it is because the left sacro anterior is the most common position. We usually try to do a forward roll, right? So you should explain to the patient, ask her to relax well. Otherwise, if the woman keeps her abdominal muscles very tight, you will not be able to do the procedure. Okay, use both the hands. Mobilize the breech using both the hands towards which the back of the fetus. Mostly it is anterior. That's the reason why we say ECV is unsuccessful in posterior positions. So anterior positions, it is always easy to mobilize this baby. So use both hands of the baby. With the left hand, grasp the head of the baby, and with the right hand, grasp the podalic pole. So as the arrows are showing, you shift this breech into here first. At the same time, you make it transverse. The head will come here. So transverse, that's what I was telling you. This diameter should be less than the diameter of the uterus. Then only the baby can turn. What happens in frank breech? Both the legs are, the knees are extended. So that will prevent this flexion of the spine is very important. Only by this flexion, you will be able to reduce the contour of the baby, reduce the diameter of the entire baby. So in frank breech, this becomes difficult. They act as a splints. They prevent this flexion. So first make it transverse, right? Then you change your hands, so it has become transverse. So this flexion is very important. Now, once the baby has become transferred, then change your fingers. Then bring this head down and take this up. Then wait for a few minutes. Again, check the NST of the patient. Look for any bleeding. Look for any return contraction. Keep the patient under observation. Right? If there are any, sometimes the baby may go through a loop of cord, or the cord can be compressed somewhere. So there may be fetal heart abnormalities may be there. There may be placental abruption and patient starts bleeding per vagina. And all those things, fetal heart abnormalities are there. You have to do the procedure back. Okay. So change the hands and then make it cephalic. So intermittent pressure is exerted till the head is brought to the lower pole of the uterus. So now you have succeeded in doing a successful internal cephalic version. So again, NST has to be obtained. If there is any bradycardia, usually it is settled by 10 minutes. If it is persisting, that means we have gone through a loop of cord. So there is a cord entanglement. And so you have to do what is known as a reversion of the procedure should be done. So observe the patient for about 30 minutes, allow the fetal heart to settle down, look for any vaginal bleeding or signs of rupture of membranes. Then you can even apply a binder to the abdomen. So previous days we used to apply the binder and then ask the patient to come back after 1 week. So all patients are advised for a follow-up report for any vaginal bleeding, that is APH or PROM leakage, and all RH negative women who is undergoing ACV should be given 100 mics of anti-D. Then this procedure is not without any complications. So what are the complications or dangers of version? Premature labor, right? Premature onset of labor, premature rupture of membrane, APH, placental abruption and bleeding. Then entanglement of the cord, causing impairment of fetal circulation and fetal death. APH, increased feto-maternal bleed, that is in RH negative pregnancy. That's the reason why you have to give anti-D. Then very, very rarely you can find amniotic fluid embolism, which is of the grave consequences. So immunoprophylaxis with anti-D is important, and always you should get a CTG reactive after the procedure. Then what are the contraindications to do an ACV? So contraindications are whenever there is a placenta previa or the woman is already having antepartum hemorrhage, you don't do it. So if the placenta localization is important. So placenta previa, don't do. If the woman is already having hemorrhage, of course you don't do it. Then fetal causes, just now I told you about hyperextension of the fetal head. That is stargazing attitude, large babies more than 3.5 kgs, major congenital anomalies, dead fetus and at-risk fetus, that is a UJR fetus. In multiple pregnancy, there's no need to do in multiple pregnancy. You can't do also. And then already the patient has ruptured the membranes. Any congenital malformations of the uterus, you will not be successful. Then if it is an at-risk fetus, already if you have done an NST prior to the procedure and you find it non-reactive, then better not to do. Then contracted pelvis, I have already told you, there is no trial of labor in breech presentations as you have in vertex presentation. Then previous cesarean delivery is very important. You are not supposed to do. Then any other complicated breech, we have already told that breeches are divided into complicated and uncomplicated. Whenever there are other obstetric complications, it's a complicated breech, like severe preeclampsia, elderly primary BOH, recurrent pregnancy loss, oligohydramnios. So all those complicated breech don't do. Then RH isoimmunization, that means the baby is, the mother is already, indirect Coombs test is already positive. That means the mother is already immunized. So don't do, because you are increasing further immunization of this woman, because FMH will be there when you do an ACV. So don't do an already immunized woman. So breech with extended legs, that's what I tell you. It's not a contraindication, but it's difficult to do an ACV. Then indication for C-section, of course, nowadays for all breech, particularly primary breech presentation, we are doing a C-section. That's the reason why primary cesarean section rates are increased throughout the world. because most of this breech presentations are delivered by cesarean deliveries. So there's no need for an indication. Breech itself is an indication. But anyway, large baby, then at-risk fetus like IUGR or preterm, any contracted pelvis, stargazing attitude, then footling presentations, previous pregnancy loss. Nice. Then when you have to terminate, say it is a preeclampsia, it's a placenta previa, she's bleeding, you want to terminate, then you can do it. Then uterine inertia, you wanted to do a delivery, but uterus is not acting in spite of stimulating it. Then the patient has gone into labor, but the breech is not descending. And the most important indication is cord prolapse with a live baby. Cord prolapse means if the baby is already dead, there is no need to go for cesarean. Cord prolapse with live baby, pulsations are present. So these are the indications for C-section and breech, but breech per se is an indication nowadays in modern obstetrics. So vaginal delivery, there are 3 types of vaginal deliveries, that is spontaneous breech, assisted breech, and breech extraction. So spontaneous breech delivery occurs only in that is where no help is needed for the baby. Right? The breech is spontaneously delivered just like a spontaneous vaginal delivery of a vertex presentation. So no assistance is required. So this can happen only in extremely preterm babies, very small babies, 1.2 kg like that. Preterm babies, multiparous individuals, that can happen. But otherwise, a term breech should not allow them to go for spontaneous breech deliveries. It's not possible also. Somewhere or the other, some assistance will be needed, which you call it as assisted breech delivery at some level or the other, because we said there are 3 stages: delivery of the buttocks, delivery of the shoulders, delivery of the aftercoming head. Among all these 3 stages, one stage or the other definitely needs some assistance in cases of term babies. So that is the most common type of delivery, is an assisted breech delivery. So this can happen only in extremely preterm babies. Then breech extraction is usually not done except for internal podalic version followed by breech extraction in twin babies. Only in twins we do this internal version followed by IPV followed by breech extraction. Other than that, breech extraction should be condemned nowadays because it is associated with high risk of fetal injuries. So management during the first stage, if you have allowed for vaginal delivery. So which cases you will allow for vaginal delivery? Only in multis with a good obstetric record. That means supposing she is a 3rd gravida, previous 2 deliveries would have, should be a normal deliveries, and then the baby should be okay. So multigravida with a good obstetric record, and then there are no obvious reasons for a breech delivery, like you have excluded all the causes for breech delivery, and then it should be, the type of breech should be a frank breech, right? And the size of the baby should be average, around 2.5 kg, right? Sufficient amount of liquor should be there, and it should be an uncomplicated breech, and the pelvis should be adequate. That shows that she is a multi. That's the reason why we are not allowing primaries for vaginal deliveries. If she is a multi, she has already delivered before term babies. That means her pelvis is adequate. So what are the cases where you allow them for vaginal delivery? Multis, good obstetric record, uncomplicated breech, right? Frank breech, average size of the baby. Okay. So these are the women whom you will allow for vaginal delivery. So wait for spontaneous onset of labor. So first stage of labor, don't allow them to be ambulant as you do in normal cases. So the patient should be in the bed for fear of cord prolapse whenever there is rupture of membrane, which is less in a frank breech compared to other types of breech. So fetal heart